I'd like to welcome everybody to today's presentation on assisting families through life transitions. I'm your host, Dr. Dawn-Elise Snipes. In this presentation, we're going to define life transitions, review the Flower Empower model, discuss how to create an empowering family-centric partnership, and explore the model's vision, values, and principles. We started talking about this a little bit before the webinar began, but what are life transitions? A lot of times when we see people for counseling, they're coming because they are feeling depressed or they're coming because of some other issue. And those issues may be being caused by life transitions. So we need to look at that. Life transitions can also be positive, whether it is adulting or getting married or having a new baby. Those are wonderful transitions, but they can be stressful. So the Flower Empower model explores the impact of the transition on the individual as well as the family, recognizing that all changes impact the family unit and reciprocally impact the individual. So thinking about how each of these transitions impacts the individual, the spouse or partner, if you will, if there is one, and dependents. So when you're thinking about a family unit, marriage, well, obviously each individual experiences some changes when they get into a committed relationship and or marriage. Sometimes marriage is more of a formality for people, but when they get into that committed relationship, there are changes from being single. Same thing is true with divorce or having a new baby or empty nest. And sorry, y'all. Hang on. Anyhow, thank you, Teresa, for picking up where I left off. Moves are also life transitions. When you move to a new place, it can be really stressful because you don't know where the Walmart is. You don't have the doctors, the dentists. You don't have your proximal support system, the friend down the street that you used to call. Yeah, you can still call them, but they're not going to be able to come over and let your dog out. So life transitions can be challenging when children have to move. And I grew up in Indianapolis, which used to be a big Army base city. And a lot of the people I went to school with were children of people who were at Fort Benjamin Harrison. And people who are in the military sometimes get used to moves because they're relocated frequently, but it is stressful on the individual who's moving. It's like, it's your fault we're moving, or you made the decision to move. And they want to make everything go as smoothly as possible. But it can also be stressful on the other people that are going along with the move. What is changing for them? What is stressful for them? What are they grieving because they're losing? And every transition involves a loss. It can be a loss of time. It can be a loss of friends. It can be a loss of community. What losses is the person really experiencing? And we want to ask this for every single person that's involved in this transition. And illness can also be a transition. When someone has cancer or Alzheimer's or something that is going to be an ongoing issue that's going to require changes in the family's functioning, if you will. There may be more need for caregiving and those sorts of things. So we want to recognize life transitions and the grief that goes along with it, as well as sometimes the opportunities. When you get married or have a new baby, you may grieve not having time to take a bath by yourself for a while. That will come. That will come back after the children are older. But there are positives and negatives to every transition. The Flower Empower model is a comprehensive approach. The core of the Flower is the clinician-family partnership, in which the clinician and family work together to assess need, to sustain a caring environment between, not just between the therapist and the identified patient, if you will, but between the members of the family. Sustain that caring environment so there's not a lot of blame, not a lot of irritability, not a lot of anger. Now, there may be those feelings that come up, but we need to deal with them and help the family support each other through this transition. 'Cause not everybody's going to grieve or accept the transition at the same rate. The clinician and family need to work together to identify education. The family educates the clinician about what they need, and the clinician educates them about what they need, or about what they identified they needed. Too often we assume that patients need to know things that they already know or that are not applicable to them. So it is so important, whether you are trying to help transition your community into one that is safer, healthier, more empowering, or you're trying to help a family transition. They will need different types of education, and we need to ask them, what is it that they need? And we need to help them identify and link to resources. A lot of people have never had to access resources on their own before, or haven't had to do it a lot. When you start adulting, figuring out how to get your bank account set up and your power and set up and all that stuff is a whole new thing. When you are in a family with someone who's diagnosed with an illness, an ongoing illness, you've never learned about what resources are available and how to access those resources. So we want to think about those and make sure that our clients have access to services that can help them link to resources and figure out what's available. Google is a good one. I hate to say it, but Google tends to be better than United Way Information and Referral anymore, because United Way Information and Referral only has those businesses that have chosen to take the proactive step of opting in. So there are a lot of businesses out there and service providers that are not even listed on United Way Information and Referral. Now, there are some things like social services that United Way Information and Referral has access to. But even a lot of the services, at least around here, that are offered through the churches, which helping people who can't afford diapers and food banks and things, not all of them are included in United Way Information and Referral. So one of the advocacy things that we'll get to is helping people have access to a database, creating a localized database for your community that helps people find the resources they need. Now, the STEM symbolizes advocacy activities, and there are several different flavors of these that we'll talk about. The leaves symbolize the vision, the values, and principles of the Flower Empower model. What are we trying to accomplish here, and how do we do it in a meaningful way? And then the roots feed the flower. This is the partnership between the family and the community, and the family and the clinician. Responsibility and accountability. Recognition of the value of the partnership. Recognition of uniqueness, resource identification for emerging needs, and results monitoring. And these things need to be done not only by the clinician and the organization, but also by the family. In the clinician-family partnership, we recognize the family's assessment of the situation as essential. If they think something's no big deal, who are we to tell them it's a big deal? If we don't think it's a big deal, but they feel like it is, then we need to treat it as such. We need to respect individual definitions of family. Not everybody defines family as blood relatives, whether they don't have blood relatives around or it's not a healthy family of origin that they came from. Who is their family? Who is their support system? We want to respect the important role of the family in supporting transitions, and that is family as the person, as the identified patient identifies it. Who is it that is going to support you in this transition? We want to determine the desired degree of family involvement. Now, this is by the individual. If somebody is moving out and they're starting to adult for the first time, or if somebody is diagnosed with a disorder, a condition, they are sort of the identified patient. They're the one that's going through the transition. It's not a whole family thing that they're not actually making that transition, but the family's affected. So the individual needs to be empowered to say, yeah, I really want to reach out to my brother in South Dakota and try to get him involved, or I want to have this much interaction with my family, or yeah, my family's toxic and not so much. And then we want to find the desired degree of family involvement by the family. Not everybody really wants to get involved. And some family members may say, not my circus, not my monkeys. I'm out. Okay. Well, we don't want to force somebody into that fold if they are not going to be caring and compassionate and active participants. So it goes both ways. How much can family members do? How much are they willing to do to support the individual's transition? And how much does the individual want their input? We want to negotiate the roles of the clinician and family within the partnership. As clinicians, we don't want to assume a role that develops dependency. We don't want to do things for the family. We want to provide them resources to help them do it for themselves to the extent possible, but we need to be clear about what we can and will do, and they need to be clear about what they can and will do. Some people have either never had experiences with the system or have had bad experiences with the system, and thinking about reaching out and trying to access those referrals that you give them on a sheet that has a bunch of phone numbers, that's just overwhelming. And the family or the person, and for the rest of this, we're just going to talk about the family. The family members, there may not be anybody in the family right now that has the wherewithal to take that on. That may just be completely overwhelming. In that case, the clinician may need to help with making those referrals and getting the appointment set up, or supporting the person while they do it. Okay, I'll sit with you. If it feels scary to do, I will sit with you while we go through this list and get these things done. We need to listen. Oh my gosh. There's a novel concept. We need to engage in participatory dialogue. We're not talking at them. We are saying, this is what I'm seeing is going on, or these are the needs that I think you might have. What is it that you perceive? What is it that would be helpful for you right now? We need to recognize patterns, and we'll see that in families. Sometimes the weekdays people can just plug along because they're busy, and then the weekends kind of devolve into chaos. Sometimes there are patterns in someone's illness. Stress triggers a upsurgence of their symptoms. Sometimes there are patterns in behavior that we see between families that we've worked with. For example, if a family brings in a new baby, the existing children may act jealous. They may start acting out. And these are things that the family may not really comprehend if they haven't been through it before. They may think, well, Junior is suddenly becoming aggressive. Where's that coming from? not realizing they're trying to get the caregiver's attention because the baby's taking up so much time. We want to highlight family strengths instead of focusing on you need this, you need this, you need this, where the family's going, well, what do I have? We want to highlight those strengths. We want to highlight the support they have for one another. We want to highlight the fact that they care about one another. Even if they don't have a lot of resources, they have strengths. And we want to reframe challenges as communication or an opportunity. And what I mean by communication is that behavior is always communication. And if dad keeps coming home from work and getting drunk every night, okay, that's not a helpful behavior. What is that communicating? And how is that an opportunity for change? How is that an opportunity to help dad identify what's going on, why he's doing that every night, and alternative strategies? We need to look at it from a bigger perspective. Assessment has to occur in this model within the context of the family. Instead of interviewing or assessing people individually and then trying to figure out how all these pieces fit together, it's ideal to do a family assessment because then you're getting input from everybody about something kind of at the same time. So you're able to clarify differences in understanding. You're able to improve communication within the context of the family. And people are empowered to hopefully speak their mind. Now, in some families, we may see that there's a lot of hesitation at speaking up, and we'll have to address that. But it is important to understand the family context. You can, and if you've worked with kids, you know this so well. You can work with a child until the cows come home. And in session, they can demonstrate all of the behaviors that you want them to demonstrate. But then they go home to a completely dysfunctional family environment where the parents are saying, it ain't me, it's Junior. That doesn't work. You know, Junior can only progress as much as the environment allows him to. We want to identify if assistance is required to strengthen the family and what that might be. Information we need to gather is family structure and composition. Who do you consider part of your family? And is it a hierarchical thing where there's a definite deference to the older generation or a definite deference to one or both primary caregivers? What does it look like? What's the culture? What are the power and role structures within the family? Not just who makes the final decision, but even looking at those power and role structures among siblings. You may have some siblings that are more responsible, others that are more gregarious, shall I say. And you may have some siblings that take more responsibility for their younger siblings. We don't know, and we want to look at that. We want to assess their communication ability. Are people actually honestly and authentically communicating with one another? What's their access to resources? What's the environmental characteristic? And in a lot of transitions, the environment's not that big of a deal because what we're looking at is, do they feel safe? Are they getting their basic biological needs met? But when we start talking about older people and people with Alzheimer's or people with Parkinson's disease, you start having environmental issues that come up, trip and fall hazards that you've got to watch out for. With Parkinson's, when the tremors get to the point where they're difficult, there may be environmental issues associated with opening jars or even feeding themselves that we need to consider. What are the family strengths? What are the family supports? What's the family's perception of events? Some families may see whatever's going on as a good thing. Some may see it as a bad thing. Some may see it as a gift or a punishment from God. Some may see it as just happenstance and fate. And we need to understand, where do they believe this is coming from, and what element or what amount of control do they believe they have over it. And as I mentioned earlier, we need to assess the degree of involvement desired by each family member. Sample questions, just to kind of give you an idea about that participatory dialogue. Who do you want us to share the information with? I know that's kind of a no-brainer there. How can we be most helpful to you and your family during this transition? Instead of me going in and saying, okay, you have this diagnosis, or you are moving to this new place, or whatever it is, and saying, this is what you need to do. This question says, what is it that you need? What expectations do you have of me, and how can I best meet your needs? It also is a time for us to clarify expectations about what we will and won't do. If they want us to do everything for them, then we need to clarify what our role is as their clinician. We want to ask what has been most helpful and least helpful during past crises or transitions. And this helps people identify their past strengths and successes that they can build on, and problems to avoid. And this can include what's been most helpful and least helpful that clinicians have done. Sometimes people will say that case management was super helpful. Other times they will say it was more of an annoyance. What's the greatest challenge facing your family right now? And I know that's one of those kind of vague questions, but it does get to some very key issues for each individual. What is the greatest challenge that you're dealing with right now? What do you need to do to best prepare you and your family for dealing with this issue? And this can help us with case management and discharge planning. If you're not going to be with them through the duration of the transition, whatever that is, what resources, what skills, what tools do you need to ensure that everybody has what they need to deal with this transition? Who do you believe is suffering the most in your family at this time, and why? Some people will recognize, maybe I'm the one that is experiencing the transition or causing the transition, but maybe somebody else is suffering more. They're having more difficulty adjusting to the transition than I am. What is the one question you would most like to have answered right now? And this gets at, do you have any pressing concerns? Sometimes we'll have the answer, sometimes we won't, but we can do the research and figure it out. And finally, finishing up with something like, how have I been most helpful to you, and how could I improve? Or what was most helpful that we talked about today or did today? And what might be more helpful for our next situation? I find that people tend to answer the second version a little more honestly, because when you ask, how have I been helpful and how could I improve, they feel like you're going to be hurt or angry if they say, yeah, this was helpful, but this was really pointless. But if you say, what did we do that was most helpful, and what could we do next time that would be more helpful, that gives them a way to provide you constructive feedback without feeling like they are going to make you angry or something. Sources of resources and support, intrafamilial, within the family. If dad just had open heart surgery, okay, dad ain't going to be mowing the lawn for a while. So that's one of those areas. And I know that's not exactly emotional support, but if the lawn gets out of control, then the HOA may get angry, and it's a cascade effect. So recognizing what new tasks, what new duties people may need to take on during this transition to make it go smoothly. Providing emotional support within the family. Hopefully it doesn't fall to just one person, because that can be really exhausting. And then who do they turn to for support? But recognizing that within the family, there are lots of strengths. There are lots of supports. I know as a family, we went through something a few weeks ago, and my daughter really stepped up and took on some responsibilities I wouldn't have expected her to. Now, she's married, she's older. It's not like she's 6 or something. But recognizing that within the family, there are often a lot of people who can be helpful and want to be helpful if they just know how. And that's where that communication comes in. Extrafamilial is outside of the family, such as community services, training programs. These are interacting with other people or groups that may not be going through the same thing, but they're services and supports. That's great. And interfamilial, and these are between families that are going through something similar. In the military, on base, pretty much everybody there has been through it, so they can support one another. When you have a preemie, there are often support groups that you can participate in. I remember after I had my children, there was a new mom's support group that met at the hospital every Tuesday that you could attend and talk with other moms, and it was facilitated by one of their nurse practitioners that was able to help with any issues or questions and normalize what was going on. But that's interfamilial. These are other lay people that are going through the same thing and can provide you a sense of community and connection and lack of isolation, I guess. Sustaining a caring environment is also essential. We want to provide consistency with our services, with our responses. We want to provide attention to the people. When we are at their house, when we are talking to them, we are focused on them. We are not answering the phone. We're not, seeming bored. When we're there, we are consistent. We are attentive to their needs. We are hearing what they have to say. We are responsive in the way that is most helpful to them. That doesn't mean the same thing for everybody. When you have somebody who is in crisis, some people need to scream and get it out. Other people need a hug. It's very different reactions. So we need to be responsive to the person and their needs at that particular time. We need to provide empathy and validation so they don't feel like they're overreacting or underreacting. Their feelings are theirs. And sometimes this can be really helpful in families because certain people may not think it's a big deal or may not understand where other people's anger is coming from. And that empathy and validation, we can help them empathize with one another. It doesn't mean they're all going to agree how it feels, but at least they understand each other's perspective. And we want to provide safety to actually honestly and authentically communicate your thoughts, feelings, and needs. That's not always an automatic in families. Matter of fact, a lot of times it's not an automatic in families. But we do need to model this, creating safety when we are doing these family meetings, family assessments, making sure we keep a safe space. And when people do speak up, that they don't get punished or antagonized for that. But if you notice, consistency, attention, responsiveness, empathy, and safety, what is that? That's the mnemonic CARES. Those are the criteria for secure attachment. We want to model this. We want to develop a secure attachment with the family, have them feel securely attached to us, and securely attached to one another. We want them to learn the skills to be able to do that for themselves. In a caring environment, no question is a dumb question. When my mom was going through hospice, there were some questions that I thought were kind of dumb questions, and I didn't want to ask them, but I did anyway. And the hospice nurses were very accommodating about that. And understand behaviors as reactions and communication. I know I already said that, but it's worth saying again. Again, I'll give the example of my own. When my mother was in hospice, we arrived because she lived in a different state. We arrived and there was a do not resuscitate order in the middle of the kitchen table. And that was, even though I knew that that was probably something that was going on, it wasn't something that I really wanted to walk in and see front and center, because it just made the reality too real in a split second. So I got very upset, and I wanted that DNR, put it in a file somewhere next to her bed or something, but not on the kitchen table. And the hospice nurse explained to me, it needs to be here, because if emergency services comes in, if something happens and we need to use it, we need to know exactly where it is, and that's typical protocol. And I was like, okay, so I won't go into the dining room, and we moved on from there. But everybody's reactions to situations may be different. And sometimes, especially with children, their reactions may speak volumes about how they're feeling, whether they're feeling safe, whether they're feeling empowered, whether they're grieving, whatever they're feeling. They may have difficulty articulating, because there's a lot of adults who have difficulty. They're just like, I feel stressed. Well, what does that mean exactly? And exactly what are you stressed about? So for children, you can see if an adult has difficulty articulating, a child may too. And we need to understand behaviors and then explore those to help them find the words. We want to educate. As I mentioned in the video on health literacy, most people's health literacy is quite low. I think 88% of the population's health literacy is quite low. Therefore, people may not recognize the various impacts of even positive transitions. Like we talked about bringing home a new baby or moving. Dad got a promotion. Everybody's moving. Yeehaw, pack up the U-Haul. But all of a sudden, Junior is leaving behind the sports team they played on. They're leaving behind their friends. They're leaving behind the teachers in the school. Even if they didn't like it, it was familiar. And that is really jarring to children. And the caregivers may go, oh, you are going to love this new place we're going to, and it has all these wonderful things, and it's a bigger house and whatever. So the caregivers may be thinking it's a wonderful thing and not recognizing the various impacts on the rest of the family's emotions, their social circle, etc. For challenging transitions, like if grandma moves in, and grandma's typically moving in because she's having difficulty with independent living. So how is that going to impact each person in the family's interpersonal relationships, both within the family and the time they have to spend with others? Maybe they used to use that room for their sleepovers, and now they can't have sleepovers. I don't know. I'm hypothesizing. But we want to look at all pieces of life for each person and how that transition is impacting them. How is it impacting them physically? A lot of times, it may not have a large impact on the whole family physically, maybe one or two people. And when I say physically, I also mean like gastric distress because of emotional stress. How's it affecting them interpersonally? Their self-esteem, their relationships with others, their sense of connection. How is it impacting them emotionally? How do they feel about it? How is it impacting them cognitively? Transitions are change. And change causes crisis. When we're in crisis, we do not have the best cognitive abilities. Our brain is in fight or flight, not prefrontal cortex executive functioning mode. During any transition, even the positive ones, writing stuff down is really important. Recognizing that attention span, concentration, information processing, learning may be more difficult during the acute transition period is essential. And helping, for example, caregivers recognize that about children as well. So if the child's grades slip a little bit, or they seem to be more disorganized or inattentive, is it because of the transition and the stress associated with it, or is it because of something else? We want to inquire if the family needs education about available resources, insurance benefits, patient assistance programs, and public services. Insurance is cumbersome and confusing. I don't care who you are. So some people can benefit from an explanation of what's covered, what's not, because it's confusing. Patient assistance programs are available through most pharmaceutical companies that will help people who cannot afford their medication get it. You go to the pharmaceutical company's website, find the link for the patient assistance program. The doc fills out like a half-page form, sends it in, and most of the time it gets approved. Other things that we want to consider: if somebody is indigent and they go to the hospital, or even if they're not indigent, if they're moderate income and they go to the hospital, they may end up with a hospital bill that's hundreds of thousands of dollars, and their insurance isn't covering it all. So we need to help them understand that they can work with the billing department at the hospital in order to create a payment plan. And I have information about that on my case management series. But it is important to know that even if they say you're supposed to pay $5,000 a month, or you have this $250,000 bill, you can work it out to a level that is manageable for your budget and your situation. And public services. A lot of people aren't aware of the public services that they may be able to tap into, whether it is for respite care or Meals on Wheels, or who knows. The condition, the treatment options, the trajectory, and possible symptoms are also things that they may or may not need or want education on. Not everybody wants to know about all of the symptoms and trajectory of the dying process. Some people want to know. They feel better if they are educated. But we don't want to give people more information than they really want, especially while they're already in crisis. We want to see if they need to have education about how to support their loved one. A lot of people ask me about, how do I support my loved one with PTSD? How do I support my loved one with ADHD? How do I support my loved one when they're going through a divorce or a breakup? That is not automatic knowledge. How do I support my loved one who is teetering on the border of not being able to live independently, but they refuse to leave their house to go to a long-term care facility? Very common in the older population. And these are things that we can provide them information about. The impacts and reactions that might be seen in family members. So parents aren't taken aback by child's behavioral disintegration, for example. Helping children understand that, okay, caregivers may be stressed right now. That doesn't mean they're angry at you. This all goes with communication. Not everybody knows what the grief response looks like, or the acute trauma response looks like, even in adults. After we have tornadoes around here, I regularly am giving that presentation about, these are the signs that you can expect to see in people. And it doesn't mean that they are going to develop PTSD or something. It's their brain trying to reboot and process what just happened. We want to help them understand about grief and anticipatory grief. Anticipatory grief is grieving about something that hasn't happened yet, whether it's a move that you're having, or a divorce, or a death. And again, as I mentioned earlier, grief about what you've lost as a result of whatever the change is. We want to sorry, y'all. I'm trying to figure out how to shut this off.
The time is 11:40 a.m.
I know what time it is. Turn this off. Okay. That's how we'll do it. Okay. Whoops. So we want to help people understand the reactions that are going to be seen in family members, grief and anticipatory. Traumatic projection. Understanding the experiences somebody may be having, not because of what's going on right now, but because of what they've been through in similar situations. And I've been through the same thing. When my dad died of cancer first. Well, actually, my grandma did. So I had been through cancer a couple times by the time we got to my mom being in hospice care. And just knowing the trajectory of what was going to happen and knowing, quite honestly, how awful it was going to get, I had a stronger traumatic reaction with her diagnosis than I did with Dad's diagnosis because I hadn't been through it before. So when we find out about something traumatic, it may reopen those wounds or traumatic experiences that we've had in the past. And we need people to understand that. Addiction. If you've been in a family with somebody who's had an addiction and they've relapsed, then, or if you've been in a family with somebody who has an addiction and they were just a very angry person, or they overdosed, that's traumatic. So if you are around somebody in the future who has an addiction and is getting ready to go to treatment, it could trigger some of those memories of, ooh, is this going to be a relapse? Oh my gosh, I'm already getting anxious that this is going to go bad. And retirement. I know you're like, retirement? That sounds great. Retirement can be traumatic for a lot of people. And when people have experienced it, law enforcement is a perfect example. Military is another example. When people retire from those jobs, a lot of times they feel very isolated and they feel like they've lost a part of themselves. They're not interacting with their peers like they used to. So the loneliness can also be very devastating for them. And if you've had an experience with someone who did not retire well, then when you start approaching retirement or somebody you love starts approaching retirement, you may start having that anticipatory trauma because you're projecting, you're expecting the bottom to fall out. And we want to help people get a handle on that. Is that what's going on right now? Or is that based on your prior experiences? Facts in this context at this time. Self-care for caregivers is also important. How do you take care of yourself so you don't get burned out? So you don't feel guilty for taking care of yourself? Well, if you get burned out, you ain't going to be good to anybody. So taking care of yourself is essential. That's one of the guilt issues. But then what does that look like? And how can you do it? If you are the full-time caregiver for somebody with Alzheimer's disease, how do you get respite care? And it depends on your community, how you answer that question. I don't have an answer, but those are questions we have to help people answer. They may say, yeah, I would love to have 2 hours just to read a book, but how do I do that? Because I don't have anybody. Vision, values, and principles. This model is an empowering, family-focused approach to all life transitions. We need to recognize personal assumptions and values about families and their cultural beliefs and adjust care. Instead of being individual-centric or person-centric, we need to be family-centric and adjust care to maximize their natural supports and resources. We recognize that families are unique, diverse, and change over time, and that time can be years or 2 weeks. Depending on what's going on, there can be dramatic shifts in families, but our goal is to help them adjust and find that homeostasis again. Families in transitions can make informed decisions, and they do. Families have expert knowledge and skills and can determine their own needs and respond to life events. Partnerships with families are built upon mutual trust, honesty, and collaboration. I can't emphasize this enough. It's not just between the clinician and the family, but it's between all the members of the family. If there is not trust, honesty, and collaboration, then we're going to end up with too many cooks in the kitchen, so to speak. Partnerships support and strengthen families. Families are supported in their choices. Not everybody's going to want to undergo chemo. So if that's the family's choice, then how do we support them in that choice? If the identified patient decides, I'm not doing that, but the family wants them to, we're going to have to help them come to that understanding and acceptance of what is going to happen. The family members and the client or identified patient may have different and conflicting needs, and some may need more space, some may need more help, some may need more information, some may want less information. We need to ask people what their needs are. Some people may want social support. They desperately want to have somebody to talk to and do something with. Other people may want to withdraw some. They need some quiet time. And we need to help people figure that out. Advocacy. Lobbying is something that we can do. Family caregiving. We need to lobby about the importance of family members being able to have time to provide care to their family members. Public education about the legitimacy of family caregivers. And Medicaid is actually doing a good job in some states of allowing family members to actually get paid for being full-time family caregivers. Consistency in funding for respite care and research, and mechanisms within organizations for families. And that consistency in funding is really important, that we help people understand respite care is really important. Too often they focus on the disease, the disorder, the transition, and they forget about the caregivers. They forget about the importance of respite care in preventing child abuse, in preventing burnout, in preventing depression, and preventing stress-related physical disorders. And we need to advocate with members of the multidisciplinary team for or with the family. And I think we've all worked in teams like this before, where a member of the team was trying to steer the truck, and it wasn't in the direction that the family wanted to go. So sometimes we do need to advocate for and or with the family. Ideally with. We want to help the family learn how to advocate for themselves. But sometimes it can be helpful for us to step in and say, hey, Dr. So-and-so or therapist so-and-so, the family's feeling like they're not being heard, or their family feels like there's this need that needs to be addressed that they're not sure how to address. As far as the roots go, both the family and the clinician need to root their understanding and choices in the following. See what I did there? Root their understanding. Ha! Responsibility and accountability for both the clinician and the family. As a clinician, I am going to be responsible and accountable for my part, for helping the family achieve their goals, for doing what I say I'm going to do. The family also needs to take responsibility and accountability for their part and doing what they can and are tasked with. Recognition of the value of the partnership with the clinician and within the family. Yes, the clinician-family partnership is a great one, but having people start recognizing the value of the partnership within their own family, the partnership between siblings, between parents and children, how they can work together to support one another. We all need to respect the uniqueness of family and individuals within the family. Nobody's going to react the same exact way to pretty much any situation. So we need to respect everybody's reactions, everybody's thoughts, wants, and needs in this transition period without judgment. We need to identify resources for emerging needs. As a clinician, I can identify some things that I'm seeing and say, hey, it seems like you'd benefit from this. But it's also important for the family to say, well, oh, by the way, this problem has started creeping up and I don't know what to do, or I need resources to address it. So the family has to communicate to us. They can't expect us to anticipate and read their minds about what they need. And results monitoring by the family and clinician based on the family's identified goals. As clinicians, we're used to monitoring results, but it can be really helpful for families to also monitor their results so they can see their progress. They can see what's working, and that makes rapid cycle change a whole lot easier when they start recognizing, hey, we've been doing this for 3 weeks and it's not doing a daggone thing. Okay, so maybe we need to drop back and adjust course a little bit. In terms of implementation of the model, we need to ensure appropriate staffing levels and placement. The family-centered model, you're not just dealing with one person, you're dealing with a family, and it's much more comprehensive. So this is not something that you can squeeze into 45 minutes once a week. We need to ensure that all staff is oriented to family-centered care, not just the case manager or not just the clinician, but everybody who's on that team understands family-centered care. We need to ensure clinicians can effectively access the resources they need. It's great to say, hey, this would be a helpful resource, but if we can't access it, then it's not any good. We need to provide ongoing opportunities for professional development. A lot of us were not trained in child therapy, in counseling people under the age of 18. So ongoing opportunities for professional development to understand what's going on there, to understand what might be happening when somebody has Alzheimer's. There are a lot of different things that we didn't learn specifically in counseling. So for our CEUs, that can be helpful. Implement family-centered practices and policies in your organization. Create a work environment that recognizes the importance of family for employees and the impact of transitions on them. If they're having to go through shift changes or duty changes or learn new skills, that's a transition. And guess what? We need to apply the same principles to the employee and the team as we do to a family. We need to develop employee assistance programs that promote family health. If one person is sick in the family, then it's going to impact everybody. And ensure our policies promote work-life balance. In terms of outreach, I call this empowering a recovery-oriented system of care. Once we have this great idea of the Flower and Power model, we need to get the word out. We have the capabilities in our own organization, great. Now we need to get the word out to clinicians, families, policymakers, and the public that this is a new approach, just like when motivational interviewing came on the scene. We need to get the word out there. We need to provide preemptive information to assist families in managing expected or unexpected life events. Information about what are life transitions, how might they impact different people at different developmental stages, and how to access assistance and navigate the system. In terms of organizational readiness, we need to have priorities and dashboards set at your organization. What are your priorities? Because as a line staff, if I don't know what the goals are, if I don't know what the target is, I'm going to have a hard time meeting it. So everybody needs to understand what their priorities are. We need to have policies and procedures that support the work needed to achieve those priorities and dashboard goals. We need to have involvement of direct and indirect members. That means staff as well as participants, clients, whatever you call them where you're at. We need to make sure that the organization as a whole is dedicated to this mission. Provide ongoing opportunities for collaboration and supervision, and opportunities for personal reflection and counseling as needed. Some of these life transitions are going to hit really close to home for some people, and they may need the opportunity for counseling, not just supervision. Think of your experiences of supporting families during life transitions. If you could change one aspect of the care and support they received, what would it be? The Flower and Power model provides a simple, sort of, but comprehensive framework for developing a working partnership with families as they undergo transitions. What questions do you have? Alrighty, well, I appreciate you for being here today. I know this was one of those more mundane presentations. Next week, we are going to be I'm going to be doing the video on providing support to people who are functional but have a psychotic disorder.